Sandile Mahlango. I'm from Eswatini Hospice at home. I welcome you today in today's session. We appreciate your presence. We are hoping and looking forward towards a great session. Last week we had a good session. Also this week we are hoping and looking forward a good session. So with me here I have my team. Maybe before we continue the session, we would request that we keep our gadgets or cell phones in a mute mode so that they don't disturb you during the session. We are also requesting that you are to keep your gadgets on a mute, and then you will unmute when you have to say something. We also have our chat box here where you can write also your comments. If ever you have joined with other people, we hope you have registered them too, and you are joining with them too in this session. In our last session, we have a great session where we were looking at how we can prescribe an opioid. So it was facilitated by Mr. Mvila, our anesthetist from Sitegi Referral Hospital. It was indeed a great session, full of discussions and sharing of experiences. We are hoping even today we will have such a session whereby we will discuss and share our knowledge and experiences, which is the purpose of this platform, that we share what is the best practice on our side and how best we can manage different cases. We had a case presentation from our regional nurse, home-based palliative care, Tani, whom I will request later to share any progress from that patient. And then today we are going to look at how to prescribe a short-acting opioid, because that's another area we need to discuss together. So we'll be sharing our experiences together on how best we can prescribe a short-acting opioid. And then there are still some sessions to come to look at that. We are so grateful to see you back, because this will help us to be able to learn and help our clients. So meantime, may I give this opportunity for you to introduce yourselves. So you can introduce yourself on writing on chat if you are many, but let me start with Mazia Tabile to introduce herself, stating your name and surname and where you are joining us from. Sister, you can unmute yourself, sister. We cannot hear you. Please unmute yourself. Okay.
Hello.
Now we hear you, sister.
Yes, I'm Tabile Mazia from Lubombo School Health.
Thank you so much, sister, for joining today. May I give this opportunity to Nonsigelelo? Nonsigelelo? Okay. You can mute yourself, sister. You can mute your gadget. Yes, Nonsigelelo.
Hello, colleagues.
You're welcome.
Hello, I'm Nonsigelelo Ntuli, a palliative care nurse from RFM Hospital, ECHO-Eswatini. I'm with Nurse Zwane also from RFM, Palliative Care Nurse.
Thank you, RFM Hospital, for joining today. We welcome you. I see Dr. Spesihle Dlamini. You can introduce yourself, Doctor.
Afternoon, everyone. Dr. Spesihle Dlamini, Manzini Government Hospital. I'm with Team Tandazile, it's just that we are in separate rooms. Thank you.
Thank you, Dr. Taylor. Will you want to introduce yourself, Tandazile?
Good afternoon, everyone.
Yeah, well, you're welcome.
Okay. Thank you so much. We just introduced ourselves in the chat box. Yes, it's Thandazile Smelane from Manzini Government Hospital, together with Nana Shandu and Sem Numalo. Thank you.
Thank you. Thank you so much. Maybe I will give the team with me to introduce themselves. I'll give them 3 seconds each. Then we go for our business for today. Maybe I'll start with Mr. Pennington.
I'm Pennington Dlamini from Eswatini Hospice at home, Palliative Care. Good afternoon, colleagues. I'm Past Care at Hospice at home.
Good afternoon, colleagues. Prescribing again, Palliative Care Nurse and
Afternoon, colleagues. I am ECHO-Eswatini for Hospice at Home, Palliative Care Nurse.
Afternoon, colleagues. I am Natando Dlamini, a student nurse from Vanessa, continuing at Hospice at Home.
Thank you. We are hoping to see others joining us. They are texting us that they are having network challenges, but we are hoping as the session continue. Maybe before we can go in, maybe we can request Tani just for 2 minutes to share on progress concerning our last week case presentation of a patient.
Good afternoon once again, colleagues. Last week we had a presentation of a client who was a 77-year-old woman with a hip dislocation. The client had reported that she had been refusing to go to hospital due to lack of proper service, or let's say proper management, according to her. So she felt that she didn't want to go to hospital again. And then she also expressed that she lacked money for going to hospital, since she now has to hire proper transport with the hip dislocation to go to hospital. And also the client was complaining that she can no longer continue with her spiritual upliftment, as she can no longer attend church due to the illness. And also sometimes she has to stay at her sister's residential place and also leave her usual place of residence. So that's why she can no longer go to church. And also the church, she also complained that some of the church members, they are no longer that much supportive to her. So on review, we checked the client again after 7 days as promised. We discussed with the client further the plan on how we can eventually go to hospital. So we made a plan with the client's children, and unfortunately the male elder son who is working, he said he is still awaiting to be salaried so that he can be able to hire a car to take her mother to hospital. So the upside is that eventually the client has agreed to go to hospital. So now they are just awaiting the money so that they are able to hire the car. Then they promised to update on how they went at hospital. And also the client gave us numbers to contact the church elders so that they are able to come and visit her at her place of residence. And also with the pain, the client reported that with the paracoddine and diclofenac she is getting for the pain is totally controlled. when she has taken a morning dose, she now has to take another dose only in the evening. So she is able to go through the day without experiencing pain. And also the caregiver verbalized that it is now easier to continue caring for her mother, as she now has some of the hygienic material like the linen service needed to take care of the client. And they are also doing the health promotional advices they were given, like changing the client position and taking care of their bed sores. So in total, I can say we have a positive review from the case. Thank you.
Thank you so much, Tani. I will say that's the review and progress from last week patient. Maybe for now we can go through our presentation. I'm happy that we also have our doctors here. So we are looking towards a great session. Today we are going to look at on how to prescribe a short acting. It's just a summary, so we will just look in and then we will all fit in our information and knowledge to this presentation. It is an overview. It was supposed to be presented by Dr. Kombe today. Unfortunately, he couldn't make it to our session, but we could not get him now because of different commitments. But we are hoping together we will be able to come up with the few very important things to note, and we will discuss and share our information. So it's a very small presentation with few slides. After the presentation, then we will all share. So we will describe the short acting, look at available opioids, not all, but the available one. There are many in the country, but we'll look at the available ones that we have. Maybe the common, that may be common to all of us. And then we'll look at the considerations that are there when prescribing and short-acting opioid. Then we'll look some indications for short-acting opioids. And then we'll look at how to prescribe an opioid to an opioid-naive patient. We'll look at those few things together. So normally, what is a short-acting opioid? So it's an opioid that takes effect immediately, but for which effects are more short-lived. So it's a short-term drug. It has a very limited effect. So it doesn't take long in the blood. It quickly acts and then quickly be removed. So the clinical effects, they last almost 3 to 6 hours. So the onset can be 30 minutes to 40 minutes. So we say that opioid will be categorized under short-acting opioids. And normally I would not dwell much on what was presented on last week's session. So this presentation is just a build-up from the previous presentation that we had last week. If then you will need to know what was discussed about opioids, we will kindly request that you can go to the platform and then log in and access the raw materials that are there. So then another thing we can describe about short-acting opioid is that it has a maximum clinical effect. Sometimes they last 3 hours or less. So within 3 hours, it will hit its ceiling level, and then it will subside again. You will discover that by the time it finishes at 4 or 5 hours, the effect is not the same. And then these drugs are normally the best when patients don't have pain like every time or every day. So they are like drugs that are very good to be used like a PRN. So because they have a quick action. And unfortunately, the reason we have to discuss them today and help one another to discuss them is that if it's morphine, for example, it is easily used or overused or overprescribed or misused. And most of the time, it is rare that you will find a patient with opioid addiction to say, I need long-acting. They normally look for short-acting. They will say, I need liquid morphine. because it will give the patient this immediate gratification. So they are easily used. Sometimes they will go for codeine and this tramadol. So they will want this immediate drug. So they look for these short acting opioids. So they try to tell us, let's discuss how best we can move around. So these are the common ones. We have tramadol. In the country so far, we have the tramadol that can be prescribed 3 to 4 times a day, which is 6 hourly or 3 times a day. So normally these ones that we have, the short acting ones. The long acting ones, they will talk about 12 hourly or once a day. So we rarely have them here, but we normally have the one that we prescribe that will last for 4 hours or 6 hours. 8 hours or 6 hours. We'll have this one in terms of tramadol. We have also codeine, though we have been warned in our last session that the codeine that we normally have, which is the fixed dose with Panado. So we are saying that for proper management of these opioids and its effect, it's better to have these drugs in their pure form, like have tramadol not combined with another analgesia, have codeine phosphate, the 30 milligram. So it's pure, not combined with Panadol, because one is mixed with Panadol. It is difficult then we have to manage the side effects of Panadol and the codeine in the same time that we are not achieving. Then we also have our liquid morphine that is most current, and there are many others that are there that are used as short-acting opioids. So then the question is, from our knowledge now, how to prescribe an opioid, like the principle of by the mouth, by time, by the patient, by the clock. So now that we know also that one, like how to write the prescription, that it must be clear. You write the dose as it is, the time, the review, and everything in that, the stamp and the signatures. Now that we know, what things I need to consider when I'm thinking of prescribing a short-acting opioid? The fact that we know it is easily abused and easily misused and overprescribed drugs, it means that we need to assess for a risk for the patient's safety. Is the drug safe for the patient? That will include what? Doctors sometimes will say, I need to know how are the kidneys of the patient functioning. I need to know how the liver is functioning. I need to know the age of the patient. I need to know the weight of the patient. I need to know the psychosocial behavior of the patient. Is the patient not in substance abuse? You know, all those things which the patient can then use against herself to harm herself using the same opioids. Whether I'm prescribing the codeine, when I'm prescribing the tramadol, or whether I'm prescribing the morphine, the liquid, I need to consider the patient's safety, physiologically, psychologically, you know, because we don't want to see our patients now addicted or abusing this substance. So we need to assess for the risk of the patient. Another thing is that you need to consider the goals, and then you have to discuss it with the patient. So especially is the goal for improvement of pain and function with the test. The patient must know what is the purpose of this medication. You know, if I'm giving you tramadol, or I'm giving you codeine, or I'm giving you a liquid morphine, the patient must know what is it for. You know, some will then abuse it, you know, so we need to know why is it for, and discuss with the patient that the patient will properly use them, because once they are misused, then there's a problem. Before that, you consider prescribing liquid morphine, tramadol, whatever, you need to check that non-opioid therapies are tried and they are optimized, that the patient has tried them and they have not worked, you know, because the opioid receptors, they don't open to any level of pain. Normally, they begin to open up on the moderate to severe pain. So if then you're going to prescribe an opioid to a mild pain, it might not open the MU receptors. You might find that they are not yet open. And then this drug, because opioids act on the brain, they will go there and go straight to the addiction center. Then you will find that our patients now, they are addicted, and quicker as these doses, they are quickly consumed in the body. So it's very important that we check if the therapies, they have been finished as a proof that no, the pain is not well controlled. And always, if then the plan is that the pain is more chronic and would require a long-term or an extended release. So I just need to start with the immediate release first, then go to the long opioids. I cannot just initiate long-acting opioids because the long-acting, first of all, it will take time for me to ascertain the maximum dose the patient will need, you see? So it's very hard to monitor them. Once they are there, they take time to be in the body because a long-acting, especially for morphine, will take 12 hours. So I will not be able to monitor. So the short-acting will help me to know the maximum dose I need for that patient. So the best way is what? Start with the lowest effective dose and titrate slowly, you know? Looking at the patient factors that I need to consider that we have discussed in the past presentation that we need to consider first. For example, if I'm going to prescribe morphine, I need to check if really the organ failures, especially kidney and liver, are okay, because I cannot prescribe any dose. I will need a certain specialist to help me to go through that. You know, so we start from the lowest dose going up. So even with the liquid one or the immediate release, start from the lowest and then you titrate slowly so that the patient can tolerate the drug or can accept it very well to reduce the severity of the side effects. So I can monitor them very well. And then another thing you need to consider is that, will I be able to reevaluate the benefit and harm with the patient within 1 or 4 weeks of initiation or dose escalation? You know, once I've titrated a certain dose, I need to monitor the patient. Is it working? Are the side effects not severe? How is the patient coping? So that the patient does not cast away those medications. So these are the things maybe we can say they consider. There are many that we may consider from the advice of the experts. Normally, there are many indications, but these are the common ones. You may use them because of the nature of this opioid. In severe pain, moderate to severe pain, that is incident, you know, incident pain, you will consider such pains, you know. So incident pain is like procedural pain that we know now that we are going to do this operation and it's going to be severe. You may consider those drugs so that the blood supply will have enough opioid to curb any pain. We use it for uncontrolled acute severe pain. So doctors will prescribe such, especially post-op. You know, they know this is a pain that we have intentionally done. So we will maintain this acute pain. It's going to last less than a few months, and then we will take the patient out. So we can control that one, and we're going to be able to see. So we can use those drugs. Intermittent pain, the pain that it's chronic, but it's not yet stable. It's down, it's up, it's there, so you cannot tell. It's not always constant there, so you can use it because it will be short acting, so to quickly work on that pain that you don't know when it will come. Then it has come and you don't know how to deal with it, so it's better to have the short acting there. And also, most of the time we combine short acting opioids together with long acting opioid, especially when it's in the breakthrough pain. I think in our next batch of pain control, we will be looking closer to this type of pain, especially breakthrough pain, because it is underly utilized. But what we can advise that anyone with the palliative care guidelines of the country, it is very good to go and reference them. But what they are encouraging there is that any breakthrough pain, you discover that this is the pain. A patient has been on opioid control and the pain has been at 2 always. It has never shooted up, but all of a sudden in a controlled pain, then there's a pain coming up there. From just that controlled pain, then comes a pain. And especially if the pain has been less than 5, then comes a pain that shoots up high. Let me call it a breakthrough pain. But doctors normally, and the guidelines of particular usual, they are encouraging us that even if it's breakthrough pain, I'm going to prescribe a short-acting opioid together with the long-acting opioid to deal with breakthrough pain. But the doses for a short-acting opioid mustn't exceed 4. So we need to also consider, why am I prescribing this short-acting opioid? In summary, this is not limited to this knowledge, but looking at our guidelines in palliative care, we can then summarize the patient who has not been there on opioids. So we have differentiated them here. If the patient has been there, like for example, the patient was using codeine. So if the patient was using codeine or was using tramadol, and then now I want to move the patient from weak opioids to strong opioids, it's not that much difficult then, because you will find that the patient now body has accepted this opioid in his body. So you will just calculate the equivalent morphine of the moderate release, and then you will make it the long-acting BD dose, but with an immediate release as a rescue dose. So it's easier there, and normally the rescue dose is 1/6 of the long-acting dose. So it's easier in that way to start. And then you will titrate along the way until you get the optimum dose. And then if then you titrate to control the pain without causing toxicity, because normally these opioids, they can cause toxicity. So normally we aim for a dose that provides clinical benefits after 40 minutes, which may last to 3-4 hours. So if that dose will work, then we will focus on that therapy. And then later you will change from short acting to long acting, right? E.g., it's 15 morphine, oral morphine, and then immediate release PO4 hourly. Then the total will be 90 morphine in 24 hours, and then that is 45 BD long acting drug either. Then that will give us with a 15 milligram of short acting. So that's how then you are preparing for a breakthrough, and then you will control that chronic pain to a patient who already has been on opioids. But a patient who has not been on opioids, then from there, if that patient has not been using any tramadol or codeine before, has not been there. So you need to go for the regular morphine, and you start with the immediate release. So you start with the short acting actually. Start the lowest doses, 2.5 milligram to 5, so that you can see if the patient, how is the patient responding, other than giving a high dose and then chasing a patient away and without monitoring. So you will monitor there, and then you provide with the same dose as a regular dose, that should, in case the dose, there's a need for control a breakthrough pain coming, then the patient may have something. And then you record any of these doses for the patient, and increase, then should be recorded a dose of morphine by 30 to 50%. So if there's a need, normally the guidelines will advise that, okay, if then the dose is not effective enough, maybe then you can increase it by 30 to 50%. If 3 or more of the PRN doses are required per day over 2 to 3 days. So you will discover that one, you need to then increase the dose. But then if I'm not sure, I need to consult a specialist. After I've done all that, you need to continue titrate. There's no ceiling for, especially morphine, because that's the golden opioid that we have. So you need to titrate it. The others, tramadol have a limit, codeine have a limit. Most of them, they have a limit. Others, they are specialist controlled, like fentanyl. Those ones, they need a specialist because of their dependence and addiction level. So we need to refer to a specialist. So you continue to titrate. If required, you will titrate the morphine, but increase the dose only if it is clear that the pain is responding to the morphine, right? You cannot increase the morphine, but the pain is not responding. It will not help the patient. So you then need to sit down and review. So we need to increase if it is responding. And if it's responding, then we need to increase. We will increase because we know it will be effective, okay? If pain is controlled, but there's an evidence of toxicity now, the morphine is working well, but now we are experiencing toxicity, then we need to reduce the dose, and then we need to consult specialists for that, so they can help us to monitor and manage those toxicity symptoms. If pain is not controlled and there's an evidence of toxicity, then again, we also seek specialist advice and consider opioid switch. Doctors are well trained to know how to switch, but we will also look at those advanced switches on how to move to morphine to another opioid, you know. We will look around those calculations, how best you move. But then we need to understand that there is always a way we can help our patient other than to leave them on pain. Maybe to conclude on this, we say that as we are taking care of our patient, we need to handle short-acting opioids with care. You know, we have overlooked tramadol, we have overlooked maybe sometimes codeine, especially when we are prescribing this still pain. There are patients have experienced they are now used to like codeine. If you give them Panadol, they can even tell you this is not the Panadol that works for me. So you know, so we need to be very cautious. If possible, let's strive to get the pure one so that we can control it. Because once it's combined, you will find that as a nurse or a clinician, I will prescribe still pain, looking towards the Panadol there and forgetting the opioid that is inside. And the patient will develop some dependence on that opioid that is there. So we need to be handling them with caution, even with the morphine. These drugs are not for a long term. So because of how easily they can be abused. So once we have stabilized that the patient needs 20 milligrams of morphine a day, then you sweep to long acting other than to keep a patient with chronic pain on short acting. And it also reduces the burden of taking the morphine every day, you see? So you switch, but you don't take away the short acting. You will educate the patient to keep the short acting in case of the rescue dose need in times of breakthrough pain, you see? So it must be, or he must have it. So another thing is that we emphasize on the thorough assessment and close monitoring of this patient. And a patient who has been given opioid, at least be monitored. These weeks must be followed. We can give them a large stock, but let's put a mechanism of how are we going to monitor if the patient is still benefiting from the opioid and the opioid are being still used well. Another thing is that every time we have to consult specialists or a physician who are registered if we are not sure of what to do in terms of these opioids. And then also the patient's goals of care are a priority. Always we prioritize the goals of care so that we achieve exactly what we need to achieve together with the patient. And then appropriate use of opioids improves the quality of life. So if we appropriately use them, the short acting, they will improve the quality of life. Lastly, but not least, we will emphasize on the issue of combining the laxatives. I know in our government facilities, sometimes they don't have the lubricants, either lactulose or liquid paraffin or castor oil. Sometimes they don't have these things. Let's encourage our patients and our colleagues that every time I'm prescribing an opioid drug, whether short-acting or long-acting, let me have bisacodyl as my stimulant and have either liquid paraffin or castor oil or lactulose as my stool softener to avoid the issues of fecal impulsion and the constipation that is too much severe, because once a patient is now having complications of constipation, we will have now to pay more money for theater now. So we don't want that. We don't want our patient to develop piles, you see. So there are also non-pharmacological means to curb the side effects, because side effects like constipation, they are more severe on our patients. So we need to monitor them very well. That's why I've put a yellow one there. No, remember, every time you're prescribing an opioid, have a laxative there so that the patient can have and use them to avoid laxatives. So that's what I can say. Otherwise, you can go for books like the Palliative Care Handbook, Good Practice Guides. It is found also in a PDF drive. You can also get other books like the one for Sakim on pain management and palliative care, a comprehensive guide. And also you can go to our national palliative care guidelines. They can also help us to know how best we can help our patient in dealing with opioids in details, and also with the short-acting opioid. Maybe at this point in time, I can give the opportunity for the team, also you colleagues, the opportunity to to add or state your comments in this short presentation. I can say you can add. I can see there's also Dr. Spesihle and Dr. Mwamba. They are here. I hope if they have something to add for you colleagues, they will add. Also on chat box, you can also add on chat box if you want to add something. Any comment, any additions or questions, we have our clinicians here who can respond. Otherwise, those are the short opioids that we have in the country, and we need to handle them with care for our patients. Anyone with a comment or a question? Okay, Dr. Mwamba is saying thank you for the presentation. He has no comments. Anyone else with a question or a comment? Also, one thing I want to add is that knowing that short opioids can be easily abused doesn't mean or give us a certificate to withhold them from our patient who needs them, right? The key is that I need to do thorough assessment. I need to assess the need. Remember, if the patient has chronic pain that I know will be always there, it's safe for me as a clinician to prescribe. Remember, the prescription of an opioid, we follow the steps that was shared by Mr. Villa last week, that it must be well signed. It must state clearly the prescription, what was there, what was prescribed, and how it will be taken. And remember, it must go together with the stamp of the physician. So we need to have them, a complete prescription. So it must be completed. Then, but before you are thinking of that, remember, before giving the patient the 10 milligram that we have in the country or the 30 milligram that we have tablets, start with the short acting so that you can see how much the patient needs. But then don't keep a patient for a long time to rely on short acting opioids because they can be easily abused. But remember also the patient goes, unless there are indications that no, there is no other way to take the long acting in terms of maybe PO you cannot swallow, you know. But we advise that always the short acting must be kept for not for a long time. If then the patient will need a long acting dose for a pain that is always there for 24 hours, let's look for a long acting. But then let's not start with the long acting, let's start with the short acting because it is very quick. It will help us establish the efficacy. It will help us establish the maximum minimum dose or so that is needed to control that pain. But then when I've prescribed the long acting, like the 10 milligram or the 20, I need to get the total dose and then give the patient a short acting dose for any breakthrough pain. Because normally our patient, they will say, they've given me this tablet and this tablet is not working. Not knowing that the tablet is working. Unfortunately, there's this pain that usually pops up. So we need to deal with that one. I can see a comment from Dr. Dlamini that says, thank you, Sandile. That was good presentation. And thank you for the highlight that patient on long-acting opioid can still use short-acting for breakthrough pain. Where I am now. Ooh, then all things have hide. Can use oh my goodness. I'm lost now. Okay, can use it for breakthrough pain. Challenges will be the recurring stockouts in our current system. Hence, we find ourselves keeping patient on short acting forever. And that one is true. And that one is true. You find that now because we don't have the MST, we will rely on this. But we know, sometimes you end up saying, what else can I do? Other than letting the patient die, let me educate them to be on this drug. But let's continue to advocate. And guys, we know the long acting are expensive. But then for the protection of our clients, we will opt for them, then keep this. It's just that sometimes you find that then we are economizing, When I've given you the long acting, I will not calculate the short acting just for any breakthrough pain. And remember, when it's prescribed for breakthrough pain, we need to emphasize to the patient, if then it happens, you have taken the short acting more than 4 doses a day, please come back to the facility so that we can see. Or if then there's a palliative care specialist nurse or whatever, must consult in terms of increasing the dose in terms of what. Because sometimes we find the physician is prescribed lower doses for both because he's monitoring something. So maybe the kidneys are not well satisfied, so he's monitoring them. So we need to be very cautious. But we know our stock. But what we have discovered also is that we need to encourage our facilities to go pick the morphine so that we use it more. Then it will inform the budget that the morphine is used. But we are not saying use it anyhow to the people who are relevant and who needs it. Thank you. Anyone with a comment? Maybe then we move towards our case for today, which will come from RFM Hospital. If you still have a comment for this one, may we recommend that you can put it on chat, or you have a challenge in your facility in terms of opioid accessibility or in the prescription of short acting and long acting, you don't know how to move. We have doctors who are well equipped in the facilities. We are there also to advise you. Then also the guidelines are there. If you don't have the guideline for today's session, we will upload them also the PDF of these guidelines as our resource material into our resource materials in the platform. So after these sessions around 3 p.m., you will be able to access those documents. Even today's presentation will be there. Can we go for the case presentation? Are you ready, Ntuli?
Yes, I'm ready.
Okay, you can give us a few minutes. We are trying to upload your case here. Very soon we will be showing it up. But you can continue to talk. Now it's up.
Hello, once again.
And continue.
Hello, once again. Hello, once again. I'm Nonsigelelo Ntuli from RFM Hospital, up representing a case of a 68 years old male with left parotid cancer. Problem, patient now reports severe sharp pain from left cheek. Pain score is 9 to 10/10, and the pain relief medication he was using is no longer effective. Client's pain have increased from moderate to severe. He was using codeine for pain relief. Pain is now constant, radiating from left cheek to the left ear, jawbone, and top base of the skull. Chief complaints. Patient complained of headache, insomnia, severe pain radiating from left cheek to the left ear, jawbone, and top base of the head. Pain score 9 to 10/10. Significant medical history. Patient is a known outpatient on treatment since 2013. He developed a painless small mass approximately 2 centimeters wide on left cheek, January 2022. The mass increased in size. He went to Babane government for consultation and they took a biopsy specimen for histology. 29 June 2022, before results were out, patient came to RFM hospital to be enrolled on palliative care, since RFM hospital is closer to his home. He presented with a fist-sized lump on left cheek. Lump was having 3 nodes. One of the 3 nodes have already bursted to form a hollow wound with the slab and septic. He complained of occasional mild to moderate pain, but physically, mentally, and clinically stable. He was given antibiotics and started dressing with Actisol alternatively after cleaning with salty water. He was also given codeine, paracetamol, and bisacodyl to manage his pain. Patient had a wish of removing the mass, but doctors needed to see biopsy results first before they sent patient to OR. RFM Hospital Palliative Care made a follow-up on results of the biopsy done in Babane, and results were found and stated that there is no malignancy. 7 September 2022, patient was then referred to the surgical OPD for review and possible surgical intervention. The surgeon ordered client to redo biopsy sampling and histology. Patient did biopsy sampling 26 September 2022 and specimen was taken to Babane for histology and waited for results while dressing and taking medication given. 25 October 2022, biopsy result came back and revealed that client have metastatic carcinoma. RFM hospital surgeon referred client back to Babane to be seen by an oncologist for further management. The oncologist recommended client to do a CT scan. Patient did the CT scan. He has started chemotherapy at Manzini Hospital. He is also doing dressing, refilling his art, and pain medication at RFM Hospital. He was changed from codeine to morphine syrup for pain since his pain have increased from moderate to severe. Relevant past medication, codeine phosphate, 30 milligrams orally 3 times a day, bisacodyl 10 milligrams orally 2 times a day, cloxacillin 500 milligrams POID, paracetamol 1 gram orally 3 times a day. Current medications, morphine 5 milligram syrup orally 6 hourly, bisacodyl 10 milligrams orally once a day, TLD PO once a day, amitriptyline 25 milligrams orally nocturne, TPT weekly for 6 weeks, Flagyl 400 milligrams PO 3 times a day for 5 days, amoxil 500 milligrams orally 3 times a day for 5 days, Brufen 400 milligrams PO, PRN, paracetamol 1 gram PO, PRN, cotrimoxazole 960 milligrams PO once a day, albendazole 400 milligrams PO once a day for 3 days, acyclovir and metoclopramide. Social history and pertinent family history. Patient is ambulating. He has gone to tertiary. He is a retired technician at the Water Services Corporation. He's widowed. Socio-economic class, middle class, lifestyle habits. Patient is smoking and drinking alcohol. Relevant health conditions in the close family members. His sister died of cervical cancer. Advanced care directives. Do not resuscitate orders not yet discussed. Living will not yet discussed. As advanced decision to refuse treatment not yet discussed. Healthcare proxy is his son. Mental capacity, yes, assessed. The client is mentally stable. Comments or concerns, further plan of care will be discussed with his son and other family members. Review of system temperature, it's 36.1 degrees Celsius, BP 90/66, pulse it's 101 beats per minute, respirations is 18 breaths per minute, saturation 97%, pain score 9 to 10/10, ECHO it's 2. Yeah. Symptoms, patient is in severe pain, there is no dyspnea, is sometimes anxious, is not agitated, there is no depression, he is not fatigued and drowsy, there is no nausea and vomiting, he is not anorexic, he sometimes complains of constipation, but he is given bisacordial, no dry mouth and no poor mobility. Focus investigation. He did biopsy for histology and it was found that he has metastatic carcinoma. Further plan. Patient is currently on chemotherapy at Manzini Hospital. He now uses morphine syrup to relieve pain. Patient complained of pill burden, but he was advised on how to take his medication without feeling burdened. To discuss further on next visit. Thank you.
Thank you, Nduli. Thank you for such a presentation. Siyabonga of a patient with metastatic parotid carcinoma. So maybe I will open this platform for the team to share. Maybe we can give this platform for the team. Here is a patient from RFM Hospital. The patient now is reporting severe pain, sharp from the left cheek, which is ranging 9 to 10. And the pain relief medication he is using are no longer effective. So maybe we can advise. The patient is also on morphine. So he's taking 5 milligram morphine syrup PO 6 hours for the pain, and I see amitriptyline there. I also see ibuprofen. I also see paracetamol. What can we advise? what would be our advice for this patient? How best they can deal with this 9 to 10 severe pain on the cheekbone? And is currently on chemo at the Manzini Hospital. Can we help RFM to deal with this pain? I'm waiting to see on chat. I can see any hand. If anyone has a question, I'm also ready for it. Anyone with a comment from the team also, we appreciate comments. What can we advise? How can the problem be solved? The problem is severe pain, and the medication is using, which is 5 milligram morphine syrup 6 hourly, paracetamol, and ibuprofen 400 milligram, all PRN. And then there's also some amitriptyline there. So how can we assess, help them? How can they best manage? Yes, I can see Mr. Pius is saying something.
Thank you very much, RFM, for presenting such an informative case. I'm worried about the pill burden. Similarly, there are current the number of medication that the patient is to take. Maybe if you can choose among the analgesics, maybe if you can choose between the Brufen and the paracetamol, maybe choose one to reduce the pill burden. Thank you.
Thank you. I hope you've get Mr. Pius Pungayon Duli.
Yes.
Okay, I see Ms. Lamini here.
Thank you very much, RFM, for the presentation. It is very informative indeed. My concern is, how far have we gone with the pain assessment? Because we can see there are so many drugs that we're supposed to be controlling the pain if it was due to the illness or the disease. How far have we discussed or assessed the psychosocial and spiritual pain with regards to that part?
Okay, I think you can get the question, Duli, but before you respond, may I give Dr. Lamini also her hand raised. Then maybe we'll combine the two. Did you get Ms. Lamini's question?
Thank you very much. My question would actually be wanting to know for how long, because we were told that the patient was previously on codeine, and then the medication was then switched, and now the patient is on morphine, and then I think paracetamol and Brufen, and plus amitriptyline. So I just want to know how long the patient has been on this combination. And then a clarification on the morphine syrup. Is the patient on 5 milligrams, which is 2.5 mils, or the patient is actually on 5 mils, which is 10 milligrams? And I think another thing that I'm actually picking up, I saw the prescription for the Brufen. It's actually prescribed as PRN, and the paracetamol is also prescribed as PRN. So if we're actually trying to manage the pain, the PRN prescriptions are really not of that much help, because we never know where we are with the patient, or how much of the certain prescribed drug that patient is actually taking, if the dose is actually PRN. So we actually try to avoid as much as possible prescribing pain medication as PRN doses. Thank you.
Thank you, Togotela. I hope you have got Dr. Pesihle's comment and Nurse Dlamini's comment into it. Maybe you can respond with your team.
Okay, thank you very much for the comments. Okay, we are trying to assess the patient psychologically, socially. It seems as if the combination of the morphine and the paracetamol is working for her. The paracetamol, he usually uses it for when he's having breakthrough pain. Whenever he's having breakthrough pain, he uses the paracetamol. It's not long ago since he started the morphine. I can say he was initiated on morphine when he was at Mbabane. I think it's I can say it's 2 weeks back. It's not too long ago.
Okay. All right, thank you. I don't know if Nurse Dlamini is also answered and Dr.
I'm not answered, but I do understand where she's coming from. But then I'm still emphasizing on thorough assessment. We go deeper to assess the pain. What she's saying is it has been 2 weeks since she's been on the pain medication, especially the morphine. If it has been 2 weeks and the pain is still 9 to 10, there must be some problem somewhere. You might be treating something that is not responding to the medication that you are
Okay. Okay. That was Nurse Dlamini's comment. I hope you get it. Also, my question will be: we know that the short-acting morphine syrup, especially, last for 3 to 4 hours, effective in the blood. But there I saw 6-hour prescription. I don't know whether it is effective enough. Like the patient will stay for 2 hours without an opioid in the blood, and then later take another one. I don't know how that one works, or were the lab results indicating any. What was the indication to prescribe a 6-hour instead of a 4-hour short-acting? And what could have influenced the prescription of a syrup after some time in codeine? So in the switching from a codeine to the syrup, what could be the factor that's influenced the team to look towards a 6-hour dose instead of a 4-hour? Because I'm seeing instead of the pain to go down, the pain is going up. Is it not? When is the pain? In between the doses, or maybe I think that one also can help you to know in terms of the prescription, or whether our morphine works for 4 hours and then the patient has to wait for another 2 hours to take another dose. So then maybe you close the frequency of the opioid to 4 hours, then you'll be able to see how is the patient working. Maybe that one will also help to curve the 9 to 10 pain, and knowing exactly when is the pain that much severe. I don't know. Maybe you can advise better, RFM.
Okay, Mr. Masang, I cannot have a clear explanation because here at RFM we don't prescribe as nurses. It's only doctors who do prescriptions, who make prescriptions. Yes.
Thank you. Thank you. I'm seeing another comment. There's another comment from Dr. Spade saying that, and yes, for the full pain assessment, this is a patient who's widowed, initially told the mass has begun and then diagnosed and changed to metastatic cancer. So the patient, this one is a widowed patient, psychosocially, there is a problem there. And then another one is that the patient has have this mass on his chin for some time or mandible for some time. And then now he's told this is metastatic cancer. That one also needs us to go deeper. What could be aggravating the pain? So may we say that when the patient returns to your care, take some time to do the thorough assessment and diagnosing of the causes of the pain, and then plan for the care. Another one maybe we can add is that maybe you consider linking this patient to our home-based palliative care team here. They have a social worker with the team. They have a team that is always there with different volunteers. So you may find that the patient will get this multidisciplinary approach even at home. You know, some patients will talk better when they are at their home comfort. Another thing that I will advise that whenever possible, I know you have psychologists and social workers there, following the patient up in terms of knowing far better than the condition will help the patient to cope better and find ways, including non-pharmacological measures on how best he can control the pain. So that could be my advice, and then go deeper to the assessment, look at other things, spiritual, psychosocial, and emotional, and discover those strengths and weaknesses to support the patient. Otherwise, it's not okay for the patient. Though we are not sure because he's still maybe within those few weeks where we are still monitoring how he's coping with the strong opioids. But let's look closer how our dosing will work with the patient. I'm worried about the 6 hourly if there was no contraindication for it. So for the short acting opioid, the gaps might be open there. And the 2 hours, if really the pain is persistent and there, it might be difficult to control an existing pain after it has pulled through an opioid. So it's better to maintain that maximum or minimum opioid in the blood so that the pain is well controlled across. I think that one will also help you to support your patient. I guess if possible, you will share your follow-up or your progress next session on the 8th on how best have you tried concerning this patient, so we can see how best we can help them. I don't know if anyone has something to add before we can close. Our next session will be on the 8th of February. We will be looking closer now to how to monitor opioid efficacy, and we will be also looking at how best we can then support our patients who are already on opioids, which will include, we will monitor the opioids efficacy. We will then look at the side effects. How do we monitor the side effects of the opioids? And then also we will look around them, knowing that how to monitor or assess for substance abuse. Then the patient once is here, what advices can we have for such a patient? So we'll be looking closer to that one. We'll have some experts to help us also on that next session on the 8th. Thank you so much. If there's no one to add something, You can click on our feedback note shared on here on chat. Also, the resource materials will be available in our platform. All what you need to do is to click on ieco.org. Then you will find the case there. You will also find the presentation today, and we will also upload the guidelines, the soft guidelines of our palliative care that we have here. So you can access them. You will need your email and password, then you log in. You will have the materials available for you 24/7. We will also share the link as the week continues, where you can also go back and watch the session again on your own. Thank you so much for attending today's session. Let's meet next week. Thank you. Bye-bye.
Dr. Sandile, should I close the session now?
Yes, we are done for the session for today. Let's meet next week, next year session on the 8th of February. Thank you.
Okay, thank you.